Just like measuring the straight leg raise, we're gonna be on the side of the client to measure hip flexion. Okay, now what we're gonna do here is I'm gonna take one arm, I'm gonna support the knee, I'm gonna take another hand, and I just like to grab the base of the heel here. And it's very important, okay, we move in a straight line. I like to say knee towards nose, okay? And the reason for that is when we're measuring hip flexion, I just wanna know how much true hip flexion do you have before we start to get any sort of rotation. You can see as I push forward more towards her chest, notice how this part of her pelvis starts to rotate back, okay? So as I push, you start to see her kind of compensate. She's got about 105, 110. Okay, you can also talk to the client, hey, do you feel any pinching as I come in? Now, if I were to spin out into ER, most people are gonna be able to get more hip flexion without any sort of pinch, without any sort of symptoms. So the reason we wanna be very strict with coming straight towards the nose, okay, I like to control the heel because it allows me to control for any ER, IR as well. And this is just supporting to unweight the leg, so they let me do the work. And as I come up towards the nose, I'm just monitoring the other hip when I start to see it roll back, but then also just end feel on this side. And so the purpose of going straight line, first coming up and out, is I'm just looking to get indication as to, hey, how can I utilize this position for exercise? Squat variations, deadlift variations. If you have someone that gets a pinch at 90, probably not gonna be the great deadlifter. They're probably gonna have to spin out in order to get to that deadlift position. So this again is just all giving us insights as to how we can leverage exercise within the entire aggregate of all of our tests to choose the appropriate interventions that improve motion, but also reduce pain and symptoms.